Thank you both for a wonderful session. We're going to move on with our program to talk about antiretroviral therapy cases. And I'd like to introduce our next speaker, Dr. Joe Eron, who is a professor of medicine at University of North Carolina in Chapel Hill. Joe is also the vice chair of the AIDS Clinical Trials Group Network and one of our internationally known antiretroviral therapy investigators. He's been responsible for numerous key findings and development of new drugs and is currently leading the charge on HIV cure research and broadly neutralizing antibody therapies for the AIDS Clinical Trials Group Network, among his many other roles. So I'll turn the program now over to Joe Eron, who will start the discussion with case presentations, and members of the panel will be also invited to participate in some of his discussion. So Joe, I'll turn it over to you now.
Okay, so everybody got to see my financial disclosures for a while. That's fine. These are the learning objectives. We're going to talk a lot about first line. We're going to talk a little bit about what to do with women who are considering pregnant or are pregnant, considering pregnancy or are pregnant. And then we're going to hopefully get to weight gain and maybe long-acting in real life. I know Dr. Taiwo just spoke to you about that. So this is our first case, and the cases are pretty similar, but I'll walk through it. This is a 35-year-old man who was recently diagnosed with HIV infection. He has a good CD4 cell count. His viral load's less than 100,000. No comorbidities. Has a normal creatinine, and it's unlikely he's actually an American because his cholesterol is 150. His husband is negative and recently tested and is very supportive, but all his other labs are pending. So the question to you is, would you start antiretroviral therapy now? So this is an ARS question. You can go, and now means like right now. So I can't see it totaling up, and we don't have any music for Mike to sing. And so virtually everybody said yes. Almost nobody said no, and a couple people were unsure. Paul, do you want to say anything? You're the home of Rapid Start. Do you want to say anything about Rapid Start? We don't have to talk a lot about it.
Yeah, sure, Joe. I think I think there's a general consensus, certainly here in San Francisco, that Rapid Start really is an important part of our effort. But having said that, I think there are a lot of people who will push back a little bit and say, if the patient is coming in through the ER and you don't have a system set up, maybe the next day is not so bad. But I think as soon as possible, and I would. This is a kind of an ideal person to consider that in. Yeah,
thanks, Paul. I think that's right. I'm not going to belabor this. I think maybe the most important thing you said is this. The system set up, having a system to do this. We don't have a great system here in Chapel Hill. We try to start people as quickly as we possibly can. We're in a red state. Hopefully we'll become a blue state, but so we don't have expanded Medicaid, so we have some issues. There are good data showing actually improved mortality. Now, these data are mostly from the developing world, but show a benefit to mortality, show a benefit in terms of loss to follow-up. And I think the people in San Francisco, and this is what Dr. Volbening was talking about. This is from the Rapid Start program in San Francisco. And I think what you can see here is these are really hard to treat people, right? There are a lot of people. Half of them had some substance abuse issue. Almost half had some mental health diagnosis. A third were unstably housed. And yet they had this really terrific response. And in this most recent paper from a year ago, they actually had longer-term follow-up, and 92% remained suppressed at their last time of follow-up. So it definitely works. I think it engages people. But again, it's the idea is to get people on therapy as soon as you can. and certainly don't give someone medication if it's not, they're not in a stable, responsible setting. But you can see that if you have the right system in place, like Paul and I think Chris Pilcher might have helped start this, and others have set up, it does really work. Okay, so
for just a second.
Yeah, please do jump in.
Comment from the audience about rapid start needing to include thoughts and feelings of the individual patient, that it's not just up to the doctor to make a decision about rapid start. So just wondered if you want.
Yeah, no, our job is to provide advice, and I think, our job is to provide advice with some level of certainty, I think, but it is certainly the patient or client, it's their prerogative, and to, start therapy, to refuse to start therapy or to start therapy, delay the start of therapy. I think what I'm talking about mostly is how convinced are we that you should start as soon as possible. And when I speak to patients, I tell them I'm very convinced that it's important to start as soon as possible. I don't go into the data. I'm sure virtually everybody on the call knows about the START study, and really people with very high CD4s, substantial benefit and really serious outcomes, including AIDS outcomes and cancers. And so I bet most of the people on this call would feel similar.
Joe, this is Paul. Just to correct what you said, I take no credit, nor would I be given credit for having started Rapid here. Happened
okay. Well, I don't know. I bet many people on that paper consider you a mentor at the very least. So now our second question. So this is a very, remember, this is a very stable person. Turns out you got some of these tests are pending, but you happen to know his creatinine and his cholesterol. Just there's no right or wrong answer here. Just let me know what you would choose for this patient. So go ahead and vote. Femi, while people are voting, what would you do here?
Well, I would use dolutegravir plus TAF FTC, and the reason for that, I think Joe. But because I'm thinking about 3 months from now and what I would do.
Yep. It looks like the group, again, the vast majority of the group would pick bictegravir TAF FTC. We're going to talk a little bit in the future about starting with 2-drug therapy. Connie, what would you pick in this setting?
I guess I'm not quite in the realm of feeling completely comfortable with starting with 2-drug therapy. I know we're accumulating a lot of evidence to suggest that 2-drug therapy may be appropriate in certain settings, particularly for those with low viral loads, but I would like to see longer-term follow-up and outcome from initiating 2-drug therapy before I make that decision myself. I think in our part of California, we're very much into the bictegravir TAF FTC regimen because it's one pill. And I think a lot of the other ones on the list are appropriate as well, with dolutegravir TAF FTC being probably our second choice here. Most of our group would not start bacavir regimen until we had testing results for HLA-B5701. But I think I would go with the option that the audience chose, bictegravir TAF FTC.
And you probably would go to a 3TC only backbone until you get the hepatitis results back, right?
Right. Yeah, and I think that's what Baba Femi, who I think of the kind of the beacon of 2-drug therapy would say, and I'll show the 2-drug therapy in a minute. But I think the point here is that I think most of the audience that's very sophisticated, and certainly most of our experts, would start with to put it simply, a second generation integrase inhibitor. And with the second generation, either bictegravir or dolutegravir, I think we're all comfortable with not knowing the resistance test, not knowing the viral hepatitis, as long as we include a tenofovir component to that therapy. And these are the kind of the current guidelines. The IAS-USA guidelines will be coming out soon. I know many people on the call on the panel have worked really hard on the IAS-USA guidelines that will be coming out. I'm going to push you, Connie, just a little tiny bit here. Is there anybody that should get a abacavir as first-line therapy for any reason?
I personally can't think of one.
Yeah, I agree with you. I think, we'll see what the guidelines show, but I think just as the guidelines have clearly completely moved away from boosting, you can see there are no boosted regimens here. I think the guidelines will potentially move away from abacavir. We'll see what the DHHS does.
Yeah. Particularly, there's one other comment from the audience about why not wait until all of the labs, especially the hepatitis B laboratory results are available before choosing a regimen. I think this just goes back to your earlier comments about the potential benefits and risks of rapid start.
Sure.
But I think that goes also into the question about that you just raised about an abacavir containing regimen. I think as we move further away from even using it in first-line therapy, the question really becomes easier in terms of rapid start. No need to start something that doesn't contain a tenofovir or TAF-based approach.
Thanks, Connie. Perfect. Okay, now we're going to switch things up a tiny bit. This is a similar person, viral load 87,000, no comorbidities, but this person doesn't come in with a partner, and he has multiple partners, some of who are HIV positive, but some of whom he's not sure. We do know some labs here. He's hepatitis C antibody positive, so he's had hepatitis C. He's immune to hepatitis B. You know that he's HLA-B5701 negative, but you also have a resistance test, and it shows some reverse transcriptase mutations. Those are old thymidine analog mutations, and then, of course, the classical efavirenz mutation K103N. There's an old protease inhibitor mutation, L90M. Some of the people on the call are old enough to remember L90M, not Connie, but Paul and I are old enough. And then there's this T97A in integrase, and I'll help people out. That's typically a polymorphism, but depending on what kind of report you get, it might show up as a resistance mutation. So again, this is a question, an ARS question. The second part of the question is for the panel, but does this change your treatment choice? You've got multi-class resistance, potentially. Does this change what you were going to do? Remember, 85% of you or so were going to give bictegravir TAF FTC. So, Babafemi, is this changing your plan?
Not too much, really, because I'll be thinking about the L97A as a potential integrase mutation, but it's a polymorphism, and we know that it really does not have an effect on dolutegravir or bictegravir. It should not. And with the TAF FTC combination, I think that gives additional support. I'll be thinking about a potential role for boosted PIs here, but again, darunavir should still be active despite the L90N. So yes, there's some reasons to think there might be issues here, but I think that it's still likely that the patient will do well.
Yeah. There's a question from the audience. This resistance pattern is in a recently diagnosed person, so.
Yeah, this is actually a case that actually the background's a little different, but the genotype comes from a case at Duke, actually, that was shared with me. So it was a recently diagnosed person.
One quick comment though is that the way it will affect my thinking is that Whereas I've started that patient first on the dolutegravir TAF-FTC and tried to switch them to dolutegravir plus 3TC in 3 months. I might be a little more cautious, I will be a little more cautious in this patient just because of that.
Yeah. So how about using dolutegravir rilpivirine in this situation?
Yeah, the concern is that it's not been studied in the naive patients. So it would not be a common choice for a treatment-naive patient. And although K103N shouldn't affect rilpivirine.
Right. Yeah, potentially that would be, if someone wanted to be on a simpler 2-drug regimen, Paul, that might be a really good transition. So that I think that makes sense.
One of the audience members is asking whether there's any value in using raltegravir at all nowadays with better INSTIs available.
Yeah, that's a great question. I honestly don't really think so. I do think that, raltegravir is a medicine we've had since, about 13 or 14 years, 2006. And we know it's very, very safe and very well tolerated. It has very few drug interactions. So I could see if maybe there are situations where you might use raltegravir, but in general, it's certainly very few people develop resistance taking raltegravir, but it does have a lower genetic barrier and pharmacologic barrier than dolutegravir or bictegravir. So I don't think so, but I could imagine you could come up with an older patient, complicated medicines, already on twice daily or already on multiple pills, perhaps. But I don't. In the IAS-USA guidelines, you on the previous slide, Connie and I and Paul are on those guidelines. We've dropped raltegravir even as recently as 2018. So.
Well, here's another question that might persuade you in a different direction. What about women who may want to get pregnant?
No, that's coming. Okay. We're gonna wait on that question because there's brand new data about that people really need to see. We have a very sophisticated audience. Most people weren't going to change their treatment, and I think that makes sense. These are data from a study that looked at either BF TAF or bictegravir TAF FTC or dolutegravir TAF FTC or dolutegravir abacavir 3TC in treatment-naive people, and they went and they actually did they had baseline resistance testing and they looked at outcomes. And in this particular study, they let in people with some NRTI resistance. They let in people with NNRTI resistance. So a substantial proportion, more than 10%, had NNRTI resistance. Some had PI resistance, and even a few snuck in with primary integrase resistance. And I suspect, because the 97A is sometimes considered a primary mutation, these might be 97A mutations. And then there are a lot of people that have integrase polymorphisms. And basically what RAP means, this is the virologic outcome. Who actually had virologic rebound? This was the resistance analysis panel. And you can see that virtually everybody succeeded. Nobody developed resistance. There were a few rebounds in the study, but nobody developed resistance. And it really didn't matter that there was NRTI resistance, NNRTI resistance, PI resistance. So that's what gives Babafemi and Connie and Paul the confidence, and most of our audience, to use a second generation. And then we in North Carolina looked very carefully at what we did. We had over 800 people that had a resistance test within 3 months of a new diagnosis. So this was our proxy for pre-therapy resistance. And what you can see is there's a lot of T97A floating around in this world, and L74M, which Babafemi might have mentioned. I didn't hear all of his talk. But these are integrase polymorphisms that don't typically have impact on our drugs. And out of 840, we only had 2 people that had evidence of pre-therapy integrase resistance. So obviously well less than 1%, less than 0.5%. Really substantial transmitted integrase resistance is uncommon. I'm going to keep going. Connie or Paul, I don't have a clock anywhere on my screen, so you know.
26 minutes left, Joe.
Okay, good. All right, that's terrific. So this this was created for Baba Femi. This is a stylized case. This is not an actual person, but it could be. This is the same 35-year-old man who has sex with men. His viral load is 187,000. It's bolded and underlined because it's higher than in the previous cases. But he has type 1 diabetes since age 15. Initially with poor control, like many adolescent type 1 diabetics, but he's now well controlled. He has a strong family history for diabetes and MI. His ALT is normal, but unfortunately, because of his long-standing diabetes, initially poorly controlled, he actually has a creatinine clearance just below 40. His total cholesterol is good on atorvastatin. He takes his medicine. He is also in a stable relationship. He is immune to hepatitis B. He's HLA-B57 negative, and he has a wild-type virus. So this is a little more complicated. So go ahead and tell us what you would pick in this particular patient. Notice that choice 1 is either bictegravir or dolutegravir plus TAF-FTC, so you don't have to make that difficult decision about that. And then why don't we, Paul? What do you think? Here's a person whose creatinine clearance is above 30, viral load less than 500,000, very adherent it appears. What would you pick in this setting?
As I unmute myself, I think I'm just liking talking about dolutegravir, rilpivirine, I guess, but this is not, not a situation where you'd use it. It's it's untreated, and his viral load is really very high, so you want to avoid that. And I probably would extend that to a lot of the two drug combinations. So I think still going for an integrase, one of the second generation integrase as your keystone drug. And then looking for something else, maybe certainly, I guess you could go just with 3TC,
right.
Adjusting it with a renal failure.
Yeah, it might not be the fixed dose combination. So Connie, you said you were hesitant about dolutegravir or 3TC. Is this someone where you might pull that trigger? I'm a little worried about a diabetic whose creatinine's already 2.6 or 2.9, whatever it was, that he may be above 30 today with his creatinine clearance, but maybe not tomorrow. Is it, Connie? What do you think? Because I know you're thoughtful but conservative in your treatment.
Yes. So this, in my earlier comments, I was being more conservative, but there are certain situations where dolutegravir 3TC might be an appropriate choice, and this is, I think, one of them. Obviously, I'd be very concerned about the creatinine clearance, the diabetes not being, we all know how difficult it has been for people with type 1 diabetes to maintain solid control forever.
Mm-hmm.
And we already have some evidence of diabetic kidney disease, so you would watch this person very carefully, but this might be a situation where the dolutegravir 3TC would be an appropriate choice.
Yeah, and I think I don't want to speak for Baba Femi, but maybe I will. I mean, this is also one where you could certainly use dolutegravir TAF-FTC, and then as soon as they were suppressed, if their viral load started to, or their creatinine started to worsen, then the dolutegravir 3TC or dolutegravir rilpivirine, as Paul pointed out, might be a good therapy. I'm going to keep going.
That's probably a good one too.
Oh.
Our audience too is concerned about using TAF-FTC in a patient with renal dysfunction.
Yeah.
Why not a boosted PI with an integrase inhibitor?
Yeah. That's an excellent question. That's choice 3. I just, we haven't really found a boosted PI plus an integrase inhibitor that we think is going to work. I mean, Babafemi and I were convinced that, darunavir, boosted darunavir and raltegravir would be the 2 great drugs. They would be so great together. And Babafemi, tell them what happened.
Yeah, I mean, it looked good, but when we looked more carefully, persons with viral load over 100,000 and CD4 count, or CD4 count less than 200, really did not do well. It did not meet, did not compare favorably. And when failure occurred, there was emergence of integrase resistance.
Yeah.
And of course, it's a BID construct too. So, because we use raltegravir then, BID.
Yeah. So generally a bad
like that.
Yeah, and we've tried boosted PI plus Maraviroc. That didn't work. Boosted PI so it probably would work. It's probably fine. It's just that we don't really, and obviously, you could give darunavir with cobicistat plus dolutegravir. It would be once a day. It would only be 2 pills. So it would probably work. But we just don't have any data to support that. And we're not crazy about boosters. But it's a good question. It's certainly not wrong. There might be a wrong answer or 2 on the slide, but actually probably not. I don't think there's a wrong answer on this slide. There are no data for rilpivirine dolutegravir as initial therapy. I personally bet it would work, but there aren't data for that.
I guess the other question about boosted, cobicistat aside, if you were using ritonavir, the patient's already on atorvastatin for control of cholesterol and has a strong family history of early MI. So that might be a boosted option you would avoid anyway. So.
Yep, no, good point. And cobicistat may have that same. Certainly, their darunavir appears to have some, myocardial infarction risk. It's modest, but it appears to be there. So, but let's keep going. Those great. You guys are terrific. These are a lot of people, including me, frequently say, I really want to see long-term therapy with long-term outcomes with 2-drug therapy. We now have, 96-week data and 2-drug therapy. I'm sure, soon we'll have 154 weeks or whatever comes next, 144 weeks. So there is long-term data, and it's really important in this study. These were treatment-naive people, got dolutegravir 3TC compared to dolutegravir FTC TDF. You can see really there is no difference. And then we just published these data recently. We looked at various viral load strata, and you can see here, greater than 100,000, no difference. In fact, numerically, the 2-drug therapy was a tiny bit better, but the numbers are really small here, and there were even a few people that snuck in with viral loads greater than 500,000 because their screening was less, but their entry was more. And there's no suggestion of loss of activity. But I, like Connie, am also still reserving my 2-drug therapy for specific situations. There's very strong data about switching to 2-drug therapy. I don't have it in there. I don't have it, in here. And I think it certainly would be reasonable to suppress someone on 3 drugs and then move to 2 drugs. Okay, so this gets to the questioner one of our audience had about women pregnant or thinking about getting pregnant. So this is a 35-year-old woman this time. She's got a good CD4, a viral load less than 100,000. She has no comorbidities. She is only on an oral contraceptive. That's her only medicine. She's in a stable relationship with an HIV-negative man. And she'd like to get pregnant as soon as possible. She doesn't have any children. She's 35 years old. She doesn't really want to wait a long time to become pregnant. She understands that our advice would be that she should have her viral load suppressed first. She has wild-type virus. She's doesn't have hepatitis C. She's immune to hepatitis B. What would you choose? And I'm warning you, there are interesting new data that some of you, maybe everybody's seen, but we'll see. Connie, I'm going to resist asking the woman on the panel. It always seems like because it's a woman patient, we should ask the woman on the panel, but
Sally's on the panel.
Oh, Sally. Oh my God. Sally, your picture's not here.
I tried to get a word in edgewise twice, Joe, and I couldn't.
Now your picture just appeared because you didn't talk.
Okay, I'll talk.
Yeah, I'm so sorry.
No, believe me.
Okay, now the floor is yours. You can have the floor for the whole rest of the talk.
Women.
I am so sorry. Oh, you can see what people said, though. This is very interesting.
This is absolutely interesting. And the data that I assume Joe is referring to are obviously the continued data that have come out about dolutegravir. Several years ago, data came out of Botswana where there's no folate replacement or supplementation, that dolutegravir, when it was used in women who were becoming pregnant and early on, there was an increased incidence of neural tube defects in the infants, which is of course very, very serious. As time has gone on, we've seen that risk come down as there have been more and more women in the studies. And I think that it was very interesting at the time those data came out. Of course, the knee-jerk was that women should not use this, and there was a very vocal contingent from Africa as well as other parts of the world of women saying that you need to really present us with the risks and the benefits, and we need to be part of the decision making. And I think that was really very important. What I would do, I think on the list, the ones that I would not choose are bictegravir. There's not data, I think, sufficient to consider it safe. I think that efavirenz, we used to be concerned about neural tube defects, but subsequently we now know from the pregnancy registry that the incidence of neural tube defect in infants is not greater. I think raltegravir actually has an established safety and is one of the agents of choice in the pregnancy guidelines. So I think that's a good choice. And I think dolutegravir, this woman is not pregnant, she wants to conceive. And I would sort of distinguish, if you look at the pregnancy guidelines, what is recommended now is that you don't stop what they're on if they're being suppressed and switch to something else, because the risk is losing control. But I think that it's a bit different when a woman wants to conceive, and I would discuss with her the risks. I've had women who have had pregnancy mishaps and are very sensitive to that and would feel much more comfortable with raltegravir. And I think that there are other women who, once you look at the data and show them the risk is coming down, would prefer to go with dolutegravir. So I think that, they could go either way. I think tenofovir and 3TC or FTC have been established to be safe in pregnancy, and that would be sort of the new backbone that I would select.
Great. So that was fantastic, and I don't have to talk about my next slides because you just did it.
Well, but the one thing you have to do, and I mean I have been guilty of this, is somebody tells you she wants to get pregnant, you make sure that she has folate supplementation.
Yeah. Oh, yeah. That's so important.
It's really easy when you have a busy HIV clinic, to sort of forget that. So that is really, really important.
Yeah, that's super. Go ahead, Paul.
I have a question for Sally.
Sorry, I'm just keeping up with the Q&A. Our audience gives you here for treatment advocacy, and then there are 2 questions related to any comments on TAF versus FTC during pregnancy or in patients who want to conceive.
It's coming. I will address those questions. Paul, go ahead.
Paul, go ahead.
So I guess the question I had for Sally was, I know there's not prospective data yet from dolutegravir, but I tend to think of Vic and Dol as so comparable, and now that we're feeling very comfortable about dolutegravir, is there any real reason to think that it's going to be different? I know that's heretical, but just floating it out there.
Well, I mean, but the thing about it is, if there were, I think we have two other really good choices that we're more comfortable with, right? So I'm not sure personally that there would be a compelling reason. And there are all sorts of, old examples about things where the animal tox looked okay, but when it got out in millions and millions of people, the drug, then you saw effects, particularly teratogenic effects. So I would err on this side. I mean, pregnancy is not a permanent condition. It's 9 months. And, I think, and you really, yeah, thank God, yeah. The stakes are high, and I think that, that is a place where I would go with drugs that we had some experience with.
Yeah, so Sally was so right on target. What you can see here is that these are the guidelines from April, so before the new data came out, and one is that dolutegravir is recommended for women no matter where they are in pregnancy. So there's no restriction. We used to talk about, don't use it during the first trimester. So remember, wherever you are in pregnancy, dolutegravir is a preferred drug based on our guidelines. And then it is actually an alternative, just as Sally said, for women who are trying to conceive. And then the third bullet is what Sally said exactly, which is remember to make sure women take folate. And this is before the guidelines panel, I assume before the guidelines panel saw these data. These are the data that were presented in AIDS 2020 online, showing the continued decrease of the risk of neural tube defects with dolutegravir. Now they have over 3,500 women exposed, and there are only 7 neural tube defects. You might remember that when it was first reported, it was 4 out of 400. So they've added over almost 3,200 more women and had only 3 additional infants with neural tube defects. So it's not the same as they see with efavirenz. It's still higher by a small amount than they see with efavirenz. And so I think the discussions that Sally was talking about, you would still have them because perhaps there's some elevated risk. But remember, these women the grain in Botswana is not supplemented with folate. That's what we know. So you can see that you can see with efavirenz, the risk is very low, which is, I'm sure some of you out there are old enough to remember we thought efavirenz would be, just could never be given to someone who is thinking about conceiving. And it turns out, it's as safe as nothing, basically. That's the same rate that you see in women without HIV who are not getting any medication. So, but now these data were presented at CROI. They were presented by Lamek Chanula, who's a OBGYN in Malawi as part of the IMPACT network. And this is a busy slide, but I'll make it simple for you. These were women who were found to be pregnant. They could have started therapy, but they had to be on, I think, less than 14 days of treatment. And then they were randomized to either dolutegravir with FTC TAF, dolutegravir with FTC TDF, or the 3-drug therapy, efavirenz, FTC TDF. So this was about 200, a little over 200 pregnant women in each arm, so not an easy study to do. Not surprisingly, more women were suppressed with dolutegravir, less than 200 at the time of delivery. This was a significant difference between dolutegravir and efavirenz. Women who are pregnant are more likely to be suppressed. But these are the data that I think might change what we do. This is looking at adverse outcomes, both adverse pregnancy outcomes, adverse birth outcomes, and just the red is actually dolutegravir, FTC, TAF. Whoop, no, I didn't mean to do that. I'm sorry. And actually TAF had the least proportion, the smallest proportion, of adverse pregnancy outcomes, less preterm delivery, less small for gestational age. There's some significant values here. There's some values that aren't significant, but numerically different. And then smaller numbers of stillbirth, though was actually lowest with the efavirenz FTC TDF. So the guidelines people in April probably didn't have time to digest this information. And I think it's an open question whether TAF will now be added as an appropriate drug for women who are pregnant. Connie, do you have an opinion? Do you think this is enough? These are enough data, or do you think it's still a little too early?
I'm very impressed with these data. It was a very carefully done study, and I think the data are appropriate. I think there's one question, although never mind, but I think it's still worth talking about. While the risk of neural tube defect is higher with dolutegravir versus efavirenz, is it statistically significantly higher or just a modest effect?
It is statistically significantly higher. That's the risk difference up here. Well, I don't know. It includes 0.0, so I think it would be 0.05 on the Richter scale so I think it would be right at that edge of significance.
I think though the comparator, Joe, has been to non-dolutegravir, right? So when you compare dolutegravir exposed to non-dolutegravir exposed, it's not statistically significant.
Yeah.
That's supposed to
it's numerically higher, but I didn't include that slide that had all the comparisons, but I think it is, for example, statistically higher than women without HIV, for example, and because there's more power in that because they have a lot more women without HIV. So there's probably, in the absence of folate, in a developing world country, there probably is some small risk of dolutegravir. That's very small risk, but there's some uncertainty about that. All right, let's get to
the realm of we can use dolutegravir TAF regimens then.
Yeah, I think so. I mean, I think the benefits of using that. Now, just curiously, right, and I actually have not reviewed this poster, maybe other people have. There was a meta-analysis that looked at multiple dolutegravir-based studies and multiple efavirenz-based studies in women who are pregnant. And they looked at transmissions. And in this meta-analysis, there were 0 transmissions in the efavirenz studies and 5 in the dolutegravir studies. Now, that's a very small number. I don't know if you would make anything of that. But I will say that in this study, it surprised me a tiny bit that there was one infant who became infected, even though maternal viral load was less than 40 at the time of delivery. Now, in utero infection can occur. It's thought to be uncommon, but it certainly, raised my antenna a little bit. It's probably kind of not a difference. And if we studied enough people on efavirenz, we'd probably find women with occasionally a child that gets infected. But that did kind of raise my attention that there was a baby who became infected.
Yeah.
Joe, there was a series, and it's a small number, but that looked at infants who were infected despite the fact that the mother at delivery had an undetectable viral load.
Yep.
And the correlations of that were, sort of the longer the mother was undetectable, the less likely that was. Hence the reason you want somebody to put on before. The other thing, and I did not see the poster, but I'm just wondering, frequently if a woman presents without antenatal care.
Oh, yeah, right. Good point.
You put folks on dolutegravir because you want that viral load to drop very quickly. You wouldn't put them on efavirenz.
Sure.
And, that may explain it, but I don't know. I haven't.
Yeah, we should look at that poster together sometime, because I think that's right. There might have been a real difference, and I don't know how they tried to control for that factor in their analysis. That's really smart, Sally. Thanks for adding that. Okay, let's move on, because there are two things I want to touch on just quickly. We probably won't have a ton of discussion. So this is a little bit more complicated, but this is a black woman living with HIV with controlled diabetes. She did have transmitted drug resistance at K103N. She got started on bictegravir TAF FTC, had an excellent response. Her viral load less than 40. She's seeing you after 8 months of therapy. And since starting therapy, she's gained 15 kilograms in 8 months. She has type 2 diabetes. I mentioned her A1C has increased from 6.9 to 7.7, and her viral loads target not detected less than 40, so below the detectable limit. She's tolerating her BF-TAF. She says she hasn't changed her diet or activity, and the weight doesn't bother her that much. So what do you do at this point? Do you continue the current therapy but increase metformin? Consider changing her antiretroviral therapy to address weight gain, something else, or not sure? And I'm sure there are a lot of internists out there, so they may have smarter things to do in terms of diabetes than I do, but this is the case. Baba Femi, what are you going to do?
But you are an internist, Joe.
I know, I am. And I tell my patients, you should see a diabetic specialist. And they always say, oh, you're good enough. And I say, oh, no, I'm not.
Yeah, so this patient, I don't have proof that switching her off big TAF FTC would improve her weight. I think that's the first thing. But again, but clearly something bad is going on, and diabetes is getting less controlled. So I would want to emphasize lifestyle issues as much as possible. And secondly, I would consider changing her regimen, although I don't have data yet. I'm aware of clinical trials that are planned to look at some of a different regimen for this population. And I also know that in the Tango study, patients who were switched off to dolutegravir 3TC, they didn't have a significant change in weight over 48 weeks, but there were some improvements in metabolic parameters, including insulin resistance marker based on the HOMA score. So I don't think that in this patient, TAF plus any integrase inhibitor will be ideal when I combine the advanced study into that. So I would want to take this patient off an integrase plus TAF-based regimen. And how I do that might be simply removing the TAF if I thought they would maintain suppression and they're not HPV co-infected and etc. Or be more experimental with like doravirine, TDF-FTC, if their renal function would tolerate it, while waiting for the ACCG trial to tell me if this is the way to go. But I think lifestyle issues are so critical if we can. The other advantage of dolutegravir then would be that it interacts with metformin. And so I might boost the metformin level a little bit in this particular situation without changing the dose.
Yeah, I know it's a good question because there's like a 50-50 split of what to do in our audience. So that's really useful. Do anybody on the panel have a different opinion than Baba Femi? He sounds like he's changing therapy.
I might have gone with option number one, but there's also
Johnny, you and I maybe I would have gone with option one also.
Yeah. One of our audience members suggesting adding Farxiga. I will use the brand name here, even though we're not supposed to because I can't pronounce the
Yeah, thank you. Thank you for helping us older internists. I'm going to keep moving, but I would say that there's quite a debate on whether TAF actually leads to weight gain, or is it TDF that actually limits people's weight And Babafemi mentioned the Tango study. The thing that's hard to interpret on the Tango study is most of the people came off of a TAF-based regimen, but most of those people were on L-Vitegravir, cobicistat, TAF, and that's the one PI-based therapy that doesn't happen to have a lot of weight gain associated with it. So I think the jury's out. But I think either answer is correct because we really don't know. So Babafemi, if you're considering changing therapy, what regimen would you choose? So everybody who didn't pick, just pretend you were changing therapy. What would you pick?
Yeah, like I said earlier on, I would pick either GFR was fine. Yeah. I'll pick either one or two.
Well, you got to pick one. You got to pick one of them. You can't.
I have to pick one. Fine, fine. Be like that, Joe. I'll pick one. Okay, good. All right, let's see what the audience thought.
Babafemi, the audience is completely with you. Though about almost a quarter thought maybe they would pick doravirine. So yeah, it's interesting. The one regimen we know is not associated with weight gain or very little is efavirenz TDF 3TC, which wasn't picked by anybody. So it's because of course she had resistance. Thank you, audience. You're smarter than I am. Good.
So there was also one comment from the audience too that we didn't really touch on yet, but I think is important here. I know we've been kicking around different options of changing versus trying to alter lifestyle change, but many of the early studies with effective viral control and effective antiretroviral therapy were associated with weight gain in and of themselves, irrespective of whether you were talking about integrase inhibitors or not. And one of our audience members also commented on the fact that ethnicity, gender add to the risk of weight gain and how you would address those in the context of counseling patients.
Yeah, it wasn't a coincidence that in this case that was a black woman. These are the data from the advanced study that Babafemi mentioned. Now, all the participants, I think virtually all, if not all, in this study, which was done in South Africa, were black. And you can see there's a marked difference between men and women. So the dark line is dolutegravir FTC TAF. The lighter blue line is dolutegravir FTC TDF, and then efavirenz is the red line. You can see with the efavirenz-based therapy in men, they almost a whole year they've hardly gained any weight, and even after 2 years, a single kilogram. And these weren't people with all CD4s of 100. So, but there were some people that probably had some return to health. Yet there's very little weight gain with efavirenz. And in men anyway, there's not much difference between TDF and TAF. But in women, there was a marked difference between this is the TAF-based arm, this is the TDF arm, and 10 kilograms, again, that's the mean weight change. So obviously there were women like the woman that in my case, in our case, that gained 15 kilograms, so not impossible. And then many people say, well, what about maybe bictegravir is better than dolutegravir? This is sorry about the quality of the slide, but this is from Paul Sachs's paper, where he basically clearly showed that bictegravir and dolutegravir, this is C over here at the bottom left, really had the same impact on weight. And here's where you see that L-vitegravir cobicistat seems to have less of an impact. And then over on the right, you're going to see there's a ranking, TAF, then abacavir, then TDF, and then AZT, but there wasn't very much data with AZT. So I'm going to go on. I think I'm going to ask do we have time for the last case, Connie, or should we just get questions? Because Babafemi covered.
There was a question. Well, I didn't. There was a question I deflected because I thought we would cover it. And it was about whether you want to use a lead-in oral, whether you should use lead-in oral cabotegravir. every time you want to use the injection, or can you use direct to injection? So I didn't answer it because I thought you would answer it.
We'll get to it.
Answer that.
Can we go over time by a couple of minutes, or is that illegal?
Yeah, we can go over we've been answering questions kind of as we've gone along. We'll still leave some time at the end for questions.
Okay, I'll be very quick because I think there are a couple of points about this. Basically, I made people, you live in Montreal, and that's because the long-acting therapy is actually approved in Canada. You speak perfect French because I always wanted to. There's no COVID pandemic because we talked to people from Canada and asked them, well, how's it going with long-acting therapy? And they say, well, we haven't really rolled it out very well because of COVID. But this is basically someone who is suppressed on therapy, is doing extremely well on dolutegravir, TAF, FTC with a good CD4, low viral load. He travels quite a bit for work. You love him because he brings you back scotch from Heathrow Airport. He's tired of taking pills. He's thinking about HIV daily, doesn't like it. On his last trip, and this just happened to one of my patients, he landed in Germany and he didn't have any of his medicine. So he had to go to a doctor in Germany and was fortunately able to get a brief supply of his medication. And he's heard about long-acting therapy. He understands it's an IM injection. In fact, he is aware that it is like long-acting penicillin for syphilis, and he wants your advice. So what do you recommend? Would you switch to oral CAB and then go to every 4-week therapy? Would you switch to oral CAB and rilpivirine, but then go to every 8-week therapy? And there's a loading dose with that. Or would you go directly to injection? Forget the oral therapy. This probably works. Or you wouldn't do IM long-acting CAB rilpivirine. So go ahead and vote. So Babafemi, what would you do in this situation?
I would switch the patient to an injection. He seems somewhat primed for it. He's interested in it.
Yeah.
And I would, my goal would be to get him on it every 8 weeks ultimately, if he can cope with that.
And would you go directly to every 8 weeks?
No,
or would you start with every 4 weeks?
I probably will start every 4 weeks. I think that's probably what I would do.
Yeah. And you're not ready to go direct to inject yet. You would make sure they tolerated the oral therapy first.
I would. I do think that the period that was studied used in the studies was sort of long. Maybe it can be shorter than 4 weeks or something like that.
Yeah.
But yeah, right now I would still want some oral evidence of oral.
Yeah. I mean, you wouldn't use like Paul. Well, very well. Cabotegravir is a lot like dolutegravir. He's tolerating dolutegravir. Yeah, maybe they don't have a problem.
Yeah, it's probably okay, but we don't have a crystal ball, right?
Yeah.
All the evidence suggests it should be okay, but it hasn't been done. I don't want to be the first. Yeah,
there are a couple demonstration projects, but we don't know the data. Paul, you're primed to say something.
Yeah, well, I just wonder. I should know the data and just don't. But how many people had serious AEs during the oral lead-in? I think of these as two really well-tolerated drugs.
Yeah, I don't know of any, actually.
It's actually very well-tolerated.
So I'm not sure, he's already suppressed. That the dual long-acting works. I'm not sure why it wouldn't work.
Yeah.
So I was interested in going right to it, but.
Yeah, he'd probably be willing to do it, but yeah. And then I think one of the things, and this will just take a minute, Connie, I know you like to be on time. The one thing that I wonder about, so these are the data from ATLAS and FLAIR, that's pooled data. ATLAS is more like our patient, and Babafemi probably showed you this. These are people that were suppressed actually for quite a long time. They go on oral therapy, then they go to injectable, and this was every 4-week injectable therapy. And what we found was that it really worked quite well. The combination is in red, the injectables in red, the injectables in blue, the continued oral therapy is in red. So there was a slight numeric difference mostly with no virologic data, very few virologic failures. But there was some resistance. So in the ATLAS study, there were 3 people who developed resistance. So it's 3 out of, I have to remember the number. I should know off the top of my head. 3 out of 300. So it's a small number of people. But you do, unfortunately, see at least one person that developed kind of cabotegravir resistance. So that's 1 out of 300, but that's possible. And then when you look at FLAIR, now FLAIR were treatment naive people only suppressed for 20 weeks, and 3 of those people developed resistance, and each of the 3 developed 2 drug resistance, at least by genotype. So it is a little bit, there's a trade-off here. And then we saw, this is Atlas 2M, we saw this at Virtual CROI, and where people switched to every, either they were in Atlas and they switched to every 8 weeks, or they came in outside of Atlas on oral therapy and were switched to every 8 weeks or every 4 weeks. And what's interesting is every 8 weeks look pretty good. Numerically, a few more virologic failures with every 8 weeks. But if you actually looked at failures with either rilpivirine or integrase resistance, every 8 weeks clearly seemed to have a little bit more resistance and resistance with RAMs than every 4 weeks. And what's was told to me but not yet reported, for whatever that's worth, is that if you were already suppressed on every 4 weeks and you switch to every 8 weeks, you actually, none of those individuals develop resistance. So my strategy for people that want to go on injectable therapy, if they're naive and they want to go to injectable, I'm going to suppress them for longer than 20 weeks. That's just my preference. I will probably suppress people. I'll tell them, well, I think you should wait a year because I want to make sure your virus is like really suppressed. And then for people that are already suppressed, I'll probably go with every 4 weeks for a while before I transitioned every 8 weeks. And I'm going to stop at this point.
I think we're far over, so we're into our break. So let me just take the 3 questions that are in the Q&A box for the moment, and then we'd like to have everybody be able to stop for a break for a little bit. But
okay. Sorry about that.
One I think you sort of already answered, but the purpose for the oral lead-in is to assure tolerability, no reaction to the medication, get people fully suppressed. I think you guys have already addressed that. Another question had to do with the weight gain, and that was if someone's suppressed and controlled on Biktarvy but gained 20 pounds, would you consider changing to a efavirenz-based regimen? The switch studies, I know you touched on them a little bit, but didn't really talk about switching to go back to a regular weight.
I mean, efavirenz could be considered. I mean, there is generic efavirenz. There's 400 milligrams, probably has less CNS side effects, so it could be considered. I think I'm not against that. I think doravirine has some advantages over efavirenz, so I would be like Babafemi. If I was switching to an NNRTI, I would probably move to doravirine. Though we have less data on weight gain or weight loss with doravirine. So
there was a poster I think it was IDSA. It wasn't a large number, but actually there was not a significant weight gain in the doravirine.
Yes, that's right.
I think others have seen a little bit, but I really think doravirine, particularly, this person had some resistance, so you wouldn't want to go to efavirenz, as you mentioned. So I think that's a really good choice.
Yep.
And then last question is, with ongoing antiretroviral therapy studies, will we be accounting or adjusting for COVID-19 related weight gain? We're starting to recognize that as a potential issue for people who develop COVID-19 and HIV.
Yeah, I don't have an answer to that. I'm not aware of that association. Maybe one of the other panelists is.
Not me either. So
yeah.
I think it's something we'll watch for, but we'll have to figure it out as we go along, like we're doing with everything with the pandemic. So I'm going to bring this session to a close. Thank Joe and the panelists for wonderful discussions, the audience for wonderful questions.
Yeah, super.
We need to come back pretty quickly to keep ourselves on time. So let's take a short break and come back at 12:05 Midwest time. And that would be 10:05 Pacific time and 1:05, I guess, Eastern time. So whatever time zone you're in, give yourselves a 7-minute break and come back.
Thank you.